Welcome, everyone. I'm Jonathan Seltzer, the Executive Director of the Cardiac Safety Research Consortium. I'd like to welcome you today to today's virtual think tank, Cardiovascular Safety and Oncology Clinical Trials, providing clarity for a new era of cancer therapeutics. For those of you not familiar with CSRC, we are a collaboration of industry, academic, and regulatory experts established in 2006 through a memorandum of understanding with the FDA. Since that time, the CSRC has contributed to regulatory thinking and clinical trial practice with numerous peer-reviewed publications, most recently related to best practices for evaluation of cardiac issues in shocks trials, remote monitoring for cardiac safety, use of cardiovascular biomarkers, and sudden cardiac death in the young. Enough about CSRC, on to today's program. By 2017, at least 6 professional organizations had statements or guidelines on the nascent but expanding area of cardio-oncology. At that time, CSRC engaged many of those experts, as well as regulatory and industry representatives, to gather best thinking regarding risk mitigation of cardiac safety signals in oncology drug development. This publication was the result of that think tank. However, as this audience knows, that was just a first step. Since then, we've produced new compounds. We've seen increasing number of patients with cardiovascular risk factors, and we've increased our scientific understanding of the relationship between cardiovascular and oncologic disease. This increased complexity has raised questions about who should and shouldn't receive which therapies. In fact, it was exactly this question which led Mark Petrie, one of today's co-chairs, to inspire this think tank. Dr. Petrie observed that therapeutic decisions about oncology patients were affected by confusion surrounding cardiovascular morbidities. This think tank was born of that observation. Sorry, I have a little trouble here. So what is a think tank? Okay, well, at least what is a CSRC think tank? For those of you who are new to the process of a CSRC think tank, what we do is we bring together cardiac safety experts, and in this case, oncology experts from all perspectives, in order to provide guidance for regulators and clinical trialists on pre-competitive cardiac safety issues for both new and existing medical products. Generally, we find an emerging problem with the drug or in device or development. CSRC makes sure that this problem has multi-stakeholder interests in industry, academia, and regulators. Then we promote free and open discussion from all party. Even though this is being recorded, I would be proper, but you don't hold back. Let us know what you think. And I think that when you notice the breakout sessions, people will do so. From this discussion, we try to derive a consensus-driven approach to the problem to move us to the next steps. We will, from this think tank, we'll be creating a peer-reviewed publication that defines the issues, consensus positions, and area for future study. And in case you have to drop off of this, webinar will be available as durable material on the CSRC website sometime in the future. Having a little trouble here with the slide progression, sorry. A couple of housekeeping issues. Okay. We will, at the beginning of this program, we'll have some presentations that we believe highlight the current issues and accurately assessing cardiovascular safety issues. After that discussion among our faculty, each participant in the program will be assigned to a breakout session. All of us will be returned for debriefing to understand what the consensus opinions were in the other breakout sessions at the end. Unfortunately, this is this is a remote program. Unfortunately, we can't have this in person. So we ask you to please use the comment feature, the chat feature, if you have a question. The faculty will be speaking, but we ask guests to use the comment feature. And for those of you, it's hard to believe, but if people are not used to the chat feature in Zoom, at the bottom of your screen, you'll see a little chat box. So hit that. What will happen is hopefully it will work better than my slides are working now. We'll open up a chat box over here. Then you type your message in there and we'll collate and get those questions to the speakers. The last things I'd like to thank you is that this has been a long time in the planning. It's gone through many iterations, along with about as many iterations as we've had COVID variants. And we think we have a pretty good program. I'd like to thank very much our co-chairs, the Marks, from all, you could see our Mark Bonica from Colorado, Mark Petrie from Glasgow, and it's a very multi-stakeholder group. Thank to Leslie Lipka from Merck, Lala Miri Kordestani, FDA, Sigrid Klar from EMA, Ninian Lang from Glasgow, and Jim Januzzi from MGH for all their work in planning this program. So with that, I'd like to turn it over to our first set of speakers, and thank you all for attending.
All right. Well, thank you, Jonathan. It's an honor to be part of this session. So we're going to start off with a debate just to frame the discussion today. And I'm going to start off with a 5-minute perspective in terms of why we should consider doing a better job characterizing cardiovascular events in cancer trials. You able to see my slides okay? All right. These are my disclosures. So I'll begin with the observation that the last decade has seen a transformation in the treatment of cancer. And this is not only important, but good news. This is one of the diagnoses that we all fear the most. I think the topic at issue today is understanding the safety profile. And this is a 2015 paper of checkpoint inhibitor therapy in melanoma. And you can see the efficacy, but the safety here on this table is what I want to highlight. And a couple things. First of all, there are a lot of treatment-related adverse events, and it's hard as a clinician to tease this all apart. But in this table, you'll see that the majority of adverse events reported are signs or symptoms rather than diagnoses. And for example, dyspnea appears to be in balance between the groups, but dyspnea can be caused by many things. And what is the cause of this? It's hard as a clinician to understand. Now, as many of you know, subsequent to that paper was this from Johnson and Mosley looking at myocarditis from a large safety database and actually showing that there was an imbalance with these therapies and that cardiac monitoring is not routinely performed. So the true incidence is unknown. And this caused some concern. A subsequent paper here, and the initial one I showed you from Larkin is in the middle here, about 1,000 patients. You can see that reporting of cardiovascular events is exceptional in phase 3 trials, and there were no cardiovascular events reported in that melanoma trial. Of course, after that came observational data sets. I'm just showing 2 here, which clearly outlined a signal for myocarditis and has caused a lot of concern for clinicians caring for patients receiving these therapies. Now, I'm using this as an example, but I do want to underscore that the reality is actually much harder because now there are trials of combined therapy, and some of them are not immune mediated. Some of them have toxicities that may be direct vascular or cardiac, and teasing out in these combination therapies, the exact safety profile is even more complicated than the question of myocarditis, which I'm using as an example. As a clinician, what does this mean? Well, let me give you a couple cases. This is a patient I saw, a 68-year-old man with metastatic melanoma. He came in with acute decompensated heart failure. He was on checkpoint inhibitor therapy doing well. The oncology team appropriately was very concerned about myocarditis. They stopped therapy and they placed him on high intensity or high dose steroids. We were considering ATG. when we evaluated the patient, actually had degenerative mitral valve disease, looked like a flail mitral leaflet, no regional wall motion abnormalities. We thought this really isn't myocarditis, but there was so much concern. We had to get a cardiac MRI, had already received steroids, and ultimately ended up going to the OR for valve on high dose steroids, even though there was no myocarditis. But this was the level of concern. And this raised a bunch of questions. So what is the true incidence in the trials and real world populations? How do we define myocarditis? How do we characterize people and follow them and monitor them for safety? A second patient with metastatic lung cancer on checkpoint inhibitor therapy who came to the emergency room with nausea and vomiting. Now, this patient came to the ED, so a troponin was checked, as is often the case. And like many patients with cardiac disease who are ill, had a very low level of elevation in troponin. The echo, the EF was 50. There was no wall motion abnormality, but it was lower than before. So was this normal or abnormal? A lot of debate. Was admitted, the low level troponin elevation had no delta. There seemed to be an explanation for the nausea and vomiting because a family member had gastroenteritis, had a stress test with no ischemia, but that's raised the question, is this a cardiovascular toxicity? What's the relevance of the troponin? Should we have had one at baseline when they were started on checkpoint therapy, and should this be interrupted? So this raises questions. Now, in the real world, it looks different than the trials. And these are data from Lavanya Kondapalli at University of Colorado of 1,800 patients who received checkpoint inhibitor in our institution. And they're much sicker than those in the trials, over 20% had coronary disease. And in contrast to the 2015 New England Journal article I showed you, there were over 400 cardiovascular events in this population after starting checkpoint inhibitor therapy over about 2 years. And these are adjudicated outcomes. But the truth is that the majority of them are related to the cancer or their underlying disease, and that myocarditis was exquisitely rare in this population. So although it gets a lot of headlines, the majority of things people are coming in with are because of who they are or their underlying cancer. But what is the issue? It's really one of signal to noise. And you can see I'm using the incidences from the Mosley paper and Lavanya's work, that if there's a rare side effect like myocarditis and there's a true effect, although the incidence is low, you can see that if you characterize it. But if that gets mixed in with other things like cardiac ischemic events where there's no imbalance, the incidence goes up, but the relative risk goes down. And then the signal starts to diminish. Even worse if it gets mixed in with other things like heart failure that's happening in these sicker patients. Again, the incidence goes ways up, but the relative risk goes down. And so the question is how to tease out the true signal from the noise. So in the solution, well, we can continue as we are, and arguments for that may be resourcing, pace of development, scale, and the workload on the site. But maybe we should change. Maybe we should think about how to characterize patients at baseline. How many events do we need to know? What is surveillance? What's adjudication? I do think we can't slow the pace of development in cancer. We should leverage what we have, and we should be systematic, but maybe we need a standardized approach to baseline characterization, surveillance. Maybe we should think about how safety is categorized and whether that can be more uniform and more specific to cardiovascular outcomes. Adjudication, I do think it's necessary for at least a subset of events and trials, but maybe that can be tailored based on mechanism in the population, and uniform definitions will allow for the pooling of data. Thank you.
That's great, Mark. We invite Leslie to speak now. That was a great start, Mark. I think you've all got us excited, and I think you've all convinced us that we think that there is a problem with cardiovascular events in cancer trials, but we're looking forward to Leslie countering that argument. Good luck, Leslie.
Can you hear me okay, Mark?
Loud and clear, loud and clear.
Okay, great. Okay, good afternoon, everyone. My name is Leslie Lipka. I'm a cardiac electrophysiologist by training, and I'm an executive director at Merck within the clinical safety and risk management group supporting oncology drug development. I'm happy to present some thoughts as to why we do not need adjudication of CV endpoints in oncology trials. And please note that the opinions contained in this presentation do not necessarily reflect those of Merck. Oncology development programs fulfill an unmet medical need in patients who generally have an urgent need for new efficacious treatments as they have limited treatment options available. Because of this unmet medical need, oncology development programs need to be streamlined and relatively agile, keeping up as the standard of care is updated. Oncology development programs test a sufficient number of patients to demonstrate efficacy and safety while minimizing risks. Thus, these programs tend to be relatively small. They may include a single-arm trial of 100 patients for accelerated approval, followed by a randomized phase 3 trial enrolling several hundred to 1,000 patients, as an example. Drug development in oncology has been moving quickly and has been very successful. In the 25 years ending in 2017, the US FDA approved 53 oncology new molecular entities under their accelerated approval pathway. Through this route, drugs can be approved for use based on a surrogate endpoint, provided they show a meaningful advantage over available therapies, with a requirement to confirm efficacy in post-approval trials. In addition, the FDA granted regular approval for 174 oncology drug indications during these 25 years. Regular approval was also granted for 51 of 93 indications, initially granted accelerated approval. So the paradigm currently used in oncology drug development works very well, both for demonstration of efficacy as well as for assessment of safety and benefit risk. Focusing on safety, all adverse events are collected and reported, including cardiac adverse events. And as these studies are relatively small, individual events can be reviewed thoroughly. So events such as serious cardiac events are typically reviewed by multiple physicians to ensure the event reporting contains the details needed to support the diagnosis. As will be discussed in later talks, adverse event terms are encoded using the Medra dictionary, and severity is graded using CTCAE grading. Regulatory reporting is based on adverse event seriousness criteria. And in confirmatory studies associated with regular approval, overall survival is often a key efficacy endpoint that incorporates competing risks of developing fatal adverse events and dying due to cancer progression. Accelerated approvals that did not end in regular approval being granted were generally not approved due to lack of efficacy in later randomized clinical trials, and not generally due to safety issues. So, of course, we all agree that the safety profile of a drug should be assessed as accurately as possible, but development of a drug with a positive benefit risk assessment should not be burdened with adjudication of CV endpoints. Oncology development, like development of other drugs, includes non-clinical assessments and phase 1 clinical assessments with follow-up signals. So attention is closely paid to cardiovascular assessments and incorporating learnings from agents such as TKI and trastuzumab in their development and post-marketing surveillance. Later phase efficacy trials often have overall survival as a key endpoint. And overall survival includes safety within the efficacy endpoint. So why would there be a need to adjudicate cardiac events when overall survival is the endpoint? And if we're adjudicating CV endpoints, why not other important endpoints such as neurologic, hepatic, renal, or dermatologic endpoints, which may be more prevalent, often debilitating, and in some cases they may be subtle. So, of course, there's always room for improving the manner in which we develop drugs and assess their safety and communicate study results and prescribing information. And it's very apparent that lexicon is an issue. So cardiovascular toxicity of oncology agents, such as such as hypertension, arrhythmia, pericarditis, myocarditis, should not be considered MACE. MACE should be reserved for a strict definition of major adverse cardiac events, thus MI, CV death, stroke, as adjudicated for CV endpoint trials, and not in oncology development programs. And I think we all agree that cardiac adverse events would benefit from clear, universally applied definitions, so that we can all be speaking the same language, the oncologist and his or her consultants, as well as regulators, drug developers, and other healthcare practitioners. So thank you very much for your attention, and I certainly look forward to a robust discussion this afternoon.
Thanks, Leslie. That was absolutely fantastic. And just to introduce myself, I'm Mark Petrie. I'm a cardiologist from Glasgow in the UK. So really the whole spirit of today is that we really want to hear the opinions and voices of the experts on the call. So as John said in the introduction, we really hope you speak fully and frankly, and we will capture all of your opinions. And really the key about this is to write one or two documents summarizing everybody's opinions, but also to try and change fundamentally the way trials are done, certainly in some of our opinions. Obviously, Leslie offered a fantastic rebuttal to Mark's a great start, but certainly if I talk to patients or if I talk to my colleagues, cardiology colleagues, they really want to know how common cardiovascular events are in cancer trials from a perspective of heart failure, left ventricular dysfunction, myocarditis, the various vascular toxicities such as myocardial infarction, and all the arterial and venous problems we see, as well as hypertension and things like arrhythmias. So we would love to have that detail from cancer trials to present the pros and cons of these therapies. But we have to say that oncology, we really admire oncology. Oncology is miles ahead of lots of areas of cardiology in terms of diagnosing, understanding oncology conditions and treating. So we really want to work with oncologists, like we've started working with renal physicians and diabetologists. We've had some great exemplars of changing regulatory processes in the field of diabetes, which have resulted in better treatment of patients and improved outcomes. So at that point, I would really love to go back to gallery view so we can see as many faces as possible. And if you could try and put your cameras on, we really want to have a full and frank discussion throughout the next hour and a half. So can I invite the first hands or the first comments? Feel free just to unmute yourself and offer opinion. Okay, great. We've got Elad to start off with. Great.
Yeah, hi. I just had a question for our Merck representative for the purposes of understanding her objection. And to be fair, I don't know if it's a straw man argument that she's making. But is there a reason why an accelerated approval would necessarily be an argument against having adjudication? I think I would note that while the questions that are related to FDA accelerated approval are questions of patient benefit, many of the accelerated approvals, certainly that were granted in the immuno-oncology space, were done for agents that have already been approved for other conditions. So the safety profile was actually reasonably well known and doesn't vary exceptionally between different indications, certainly not in solid tumors. So I guess, the question that I have is, what's the harm, even from a drug development perspective, of looking at adjudication or better characterization of the immuno-oncology effects on the heart when they do occur? Certainly, I feel strongly that we should be doing this more often, not just in cardiology, but broadly. So to me, also that's also not an argument not to do it in cardiology. But I'm just curious if she can comment on that.
Leslie, do you want to reply? Okay, I think she maybe Leslie's saying that it was a straw man argument. Maybe she agrees with you after all. So I think she was being provocative, frankly, but she also did a great job with it. And I think highlighting the renal aspects is also fantastic, because we should think beyond the heart as well, because there are other issues. So will we go on to Lavanya now? Hi, Lavanya.
Good morning. Thank you for this opportunity to participate. So I'm from the University of Colorado, and we're a big phase 1 clinical trial center in oncology, and I'm a cardiologist. And I would just bring up that I think an important piece of this is to remember that in cardio-oncology, most of us who do this work really want to be collaborative. And so it oftentimes, when a potential cardiac side effect comes up, it does cause a lot of anxiety among both the oncologist, most importantly the patient, and so, for example, there was a phase 1 trial drug that we were seeing some bradycardia. For a cardiologist, bradycardia is really no big deal. I mean, we so rarely need to do anything about bradycardia. And even to try, I was working with the breast oncologist to see if we could even try to get the primary data from other centers to see what was the true incidence of a side effect that really is just so minor. And that was really challenging. And so I guess I would argue that I hope that the drug companies can see that we aren't looking to kill these drugs at all. We really believe that we want to figure out how do we work with these drugs to keep our patients on these drugs. And so if anything, maybe we can, by looking at these signals and kind of adjudicating for cardiovascular events during the trials themselves, I think if anything, we really just help keep our patients on these drugs and alleviate a lot of the anxiety, concern that comes up when patients may have a side effect.
Great comment, Lavanya. I think that echoes what many clinicians feel as we grapple with sort of how to deal with safety and keep our patients on important therapies for their cancer. So thank you for that comment. A few other hands up. Javed Moslehi, I saw your hand had been up. I don't know if you want to comment.
Hey guys, sorry, I am in the midst of clinical service, but I want to make 3 points or 3 examples of where I think there are some issues right now with cardiovascular adjudication in clinical trials. I actually do agree with some points Leslie made. I don't think looking at random endpoints are important, but let me give you these 3 examples. One issue that comes up is normally when a new cancer drug comes in, it's tested for patients who have no other options. And one example I'm going to give you is ibrutinib, which was a very incredible drug used for testing with B-cell malignancies. Initially was tested, there was a signal for atrial fibrillation, and 2 years ago exactly, there was a New England Journal of Medicine where it was tested instead in a frontline setting. There were 3 arms in the study, and the 2 arms, including ibrutinib, while there was a better progression-free survival, there were 7% incidences of sudden death in each of the ibrutinib arms, while the control arm only had 1% incidence of sudden death. And that's a case where a drug is tested initially for patients who have no other options. And then when tested in the front line where there are multiple options, it becomes an issue. And I think it's important because now there are multiple BTK inhibitors out there, and there's a question about what the relative incidence between the two are. The other case I want to bring up is for a drug that is a class of therapies for which there was considerable enthusiasm in the oncology space, and that is MCL1 inhibitors. This is great work by Tony Latai at Dana-Farber, showing inhibition of that is going to be effective for certain malignancies. Multiple companies have an MCL1 inhibitor, but as what we have seen is Amgen, who had the first drug, had to suddenly stop every study because of a cardiac incidence. And AstraZeneca more recently did the same thing with their MCL1 inhibitor. And the problem with lack of adjudication is we have no idea what these cardiovascular issues are with these MCL1 inhibitors. I'm just using that as an example. It could be something as simple as having a troponin increase, or it would be something more serious. And unfortunately, those data are really hard to come by because there's a lot of competition in this space. And from a drug company perspective, I think it's important to learn about this because frankly, a lot of the drugs are not exactly, are sort of Me Too drugs in this space sometimes. And I'll just bring in the example of BTK inhibitors. There are at least, and some of the FDA people can correct me, or at least I see Frank Cornell, who's an expert hematologist. There are multiple BTK inhibitors that are both approved and are being tested. And I think the relative rates are different between the drugs. So I think one issue to bring up is when it moves to frontline space where there are multiple choices. I think the second one is the vague signals that we have seen with drugs like MCL1 inhibitors in the space.
Yeah, again, great points, Javed, and thanks for coming in a busy day. So we're going to capture all of these comments and factor them in, and hopefully you've got some appetite to get involved in the publications. That's absolutely fantastic. Rudolf, do you want to come in next? Thanks.
Yes, please. Thank you, Mark. My name is Rudolf de Boer. I work as a cardiologist in Groningen in the Netherlands with a specialty in heart failure. I was wondering when we start this discussion, talking about cardiovascular toxicity, of course, is a simplification of what we see. I can imagine that we accept, let's say, hypertension or transient EKG abnormalities, whereas cardiogenic shock or myocarditis is associated with very high mortality. What I'm trying to get to is once you start measuring and collecting certain cardiac parameters in order to capture those very severe side effects, you probably capture also the not so severe and the let's say as a side effect. So it's probably a matter of either or. I can think of a scenario where you say, well, we're not going to adjudicate, but we do have a keen interest in the very severe side effects. You won't capture those either. So yeah, that was what I was wondering, how this could practically be done. Just looking at a few of the cardiovascular toxicities, I just don't, I don't see exactly how it is. So it's more of a remark rather than a question with an answer.
It's a great comment. I mean, and I think it's, to the point of, we're going to see stuff in these patients and we need to know, maybe these are benign findings. I mean, maybe there are, low level troponins, which aren't so prognostically important in somebody who's dealing with cancer. There are other things that I think would be helpful to know and be reassuring. Maybe some of these things are reversible versus myocarditis. So I think that's an excellent point. Maybe we can then go to Sigrid. Did you want to see your hand up?
Yeah, thank you. I'm here as a representative of the EMA, but I would just like to start by saying that my input here is my own and does not signify an agreed European position unless I say so. Regarding this conflict, so to speak, I think both sides have valid points. And I think the trick is to find a balance between the burden and the benefits of regulatory requirements on the clinical trialists or in clinical trials. But from a regulatory side, I think there is a point in, I mean, the problem is that, or the problem, the background for this is that, as was mentioned by Dr. Lipka, that this is in a setting where if you have an overall survival gain, there is not much that can outweigh that, so to speak. So from a regulatory side, we have quite small possibilities of requiring additional measures when the benefit risk balance is positive, so to speak. So that's the background. But from still, I think there is a point and an importance in characterizing a drug safety profile, even when you have an OS gain, to be able to risk minimize as much as possible and to avoid avoidable harm from the drug, even though in total the overall benefit is clearly positive in the target population. So risk minimization, there are reasons still to do more than just show you have a positive benefit risk balance. Thank you.
Okay, Sigrid, that's fantastic. And obviously you're representing the EMA, who along with the FDA will be absolutely vital to striking the right balance here. So we're looking forward to working with everybody here and yourselves and Lally and team. So will we go now to Susan Dent? Susan, do you want to speak next?
Sure, thank you. So I'm Susan, I'm a medical oncologist at Duke, a breast cancer medical oncologist, and been here for 3 years, before that in Canada. And I've had the opportunity to work in the phase 1, IND space earlier in my career, and then more recently moved into the whole field of cardio-oncology. So I've had the opportunity to look at it from both sides of the fence. And I'd have to say that as an oncologist, the last thing we want to do is slow down drug development. I mean, we want, the drugs to get out there and have them in the clinic as fast as possible. On the other hand, clearly, cancer drug development has changed significantly over the last 15 years. And now we are looking at CAR T-cell therapy, doublets of immune checkpoint inhibitors in very, very sick oncology patients, which means that investigators, oncologists are tasked with labeling that toxicity, what they see when they're treating that patient, grading it, and then assigning it attestation to that. And I would argue that there's a lot of responsibility, I think, put on the shoulders of the oncologist to get that right. And as I've heard from my oncology and cardiology colleagues, these cases or these patients are complex. And so are we getting it right? Are we getting it right? Are we actually assigning the right toxicity or grade of toxicity? Are we assigning it properly in terms of the attestation? And in those cases where you have complex therapies in very sick people, would adjudication at least help us try and sort out, what we're really seeing versus what we think we're seeing? And that's where I think, we can't compare clinical trials 10 years ago to what we're doing today. It's completely changed. And so I think we have to start changing and thinking about how we can change as drugs and how we're treating patients change today.
Yeah, great, Susan. So I think you're absolutely correct. We say we don't want to hold up oncology trials. We have to be sensible, and that would be a disaster for patients receiving cancer therapy. So I think we're all on the same page. So can we go to Robert Kleiman next? Robert, hi.
Sure. Hi, folks. This is Bob Kleiman. I'm also an electrophysiologist. There seem to be a lot of us around here. And I'm with Clario, formerly ERT. I think Leslie brought up a really good point that in many oncology trials, we're dealing with elderly patients who, even if they didn't have a malignancy, have underlying cardiovascular disease or at least risk factors. So that if you treat enough patients for a long enough time, you're going to have cardiovascular events. But as far as adjudication of cardiovascular events, I guess it would be helpful to know, does anyone have a sense of in what percentage of oncology programs is there actually adjudication of CV events? Because it's not 100% of them. Is it just related to drugs with known class effect or a non-clinical signal of concern?
Yeah, so I can answer that. There's been I'll talk about it in my talk a bit later. There has been an analysis looking at the last 20 years of phase 2 and phase 3 trials, and it's pretty variable. it's somewhere between 20% and 60% that do not report cardiovascular events at all. And when they do, there are issues with the definitions and the mode of capture. Sometimes we just talk about MACE, and there are challenges with CTCAE that we'll come on to. But and it is variable depending on the agent. It's probably better with the targeted therapies, but still certainly room for improvement.
Great. Well, I know we're coming up on time. We have a couple of presentations. Maybe Anna Baraki, you've patiently had your hand up if you have a brief comment, and then we'll move on to our next set of presentations.
No, I have a super quick comment. I'm actually really pleased that Dr. Lipka made this presentation and we are discussing this, because this opinion is almost an elephant in the room, and it's never on cardio-oncology groups, because we feel that we are, you know, a choir, and everybody feels that, okay, we are there to promote oncology development, but it's a huge component of the reality of the oncology drug development. I believe, and I think that this evolved from the regulatory standpoint, and could not be more glad to have Lale and Zikrid on the call to comment. So the point is, like, is the drug safe enough? So why, if there is elevation of troponin, why would we care about it if there is overall survival improvement? So I think we're all saying that the drug should be improved. The challenge that happens in clinical practice once it's approved under certain circumstances, just like you arrived, from that approach of focus on safety, paradoxically, we have zero information about how to manage risk. So I think we are sort of looking at that elephant from the other side. Nobody's saying that the drug is not safe or that cannot be continued. On the other hand, if you do not know if we are dealing with heart failure, myocarditis, a rhythm problem, then we cannot adjudicate it and we cannot mitigate that risk. So it's almost a conundrum, like, we need some kind of agreement there. But I'm really glad. I think this is the very conversation to have at this panel. Can we incorporate components which would say, well, drug is safe under these conditions? The problem is the moment you approve the drug, it goes into real world. These conditions are no longer there. We are seeing troponin elevations. You see cardiac myocardial infarction. Nobody says that drug should not have been given, but how do you manage? So that's a quick comment.
Well, and a fantastic comment, really highlights what we struggle with in the clinic and how we need to better inform practice. Well, this has been fantastic. Mark Petrie put in a comment. Please go into the chat, add your comments, all this recorded. Let's go on to our next set of presentations. And Lale, I know you're going to present on the US FDA regulatory perspective. Please go ahead.
Yes, thank you. Actually, I decided not to present the slides. The time is really short. So I just wanted to just add some comments, to just add some of my own perspective actually to this conversation. You know, as you know, like FDA continues to monitor the safety of the drugs throughout their drug development from the start of the IND. Basically, they collect the preclinical data, and then throughout the pre-marketing, there are specific guidances that I'm happy to actually send the links regarding like how we should actually collect the safety information, and then what are the, for example, some expedited safety reporting requirements for the sponsors. And actually FDA has recently, just this year, has updated some of these guidances, like giving more specific recommendations for sponsors as well as investigators. So like what are the specific things that they need to in an expedited fashion report. For example, a lot of cardiac adverse events are considered serious, so those really meet the criteria if they are unexpected and are felt to be related. But the issue is that, as you all heard, in general, the oncology trials are sort of small. So by the time that the application comes in for the assessment of the benefit, risk, and marketing approval, generally, especially if there are no alternative treatment options for the patients and we're going for an accelerated approval pathway, the size of the safety database is small. So even when we are reviewing, for example, large trials, it's very hard to tease out any, for example, these rare toxicities. So you can imagine it really becomes much harder when we only have a couple of hundred patients in terms of in our safety database to actually review any safety data. So the other thing is that more and more we see, because of the expedited nature of this drug development, that, for example, phase 2 trials are being submitted for assessment of the accelerated approval, and therefore actually, we don't have that much of information to actually assess the safety, as well as, also don't have the long-term efficacy or survival data. For example, drugs are being approved based on tumor shrinkage or response rates. So at the time, we really don't have information on the overall survival from a single arm trial. So I think the sort of comment that we have overall survival, so we don't need adjudication. Actually, in majority of cases, we don't really have survival, actually, unless we have, quite large randomized trials that are sized appropriately for overall survival, which majority of our trials don't have that. The other question that was about adjudication, I have very rarely seen adjudication happening. I forgot to introduce myself, actually. I'm sorry, I'm going back. So I'm actually a hematologist oncologist by training, and I work in a division which we review the drugs for basically breast cancer, GYN malignancies, and GU malignancies, and I'm currently the division director for this division. And I have worked for FDA for over 10 years. From my experience, actually, we rarely see adjudication happening. And obviously, there is a variety of, issues in terms of teasing out these AEs in the safety database at the time of marketing. So I think it's completely acceptable to understand that post-marketing, we are going to see these signals. And actually, the good thing is that FDA continues to do pharmacovigilance. So we continue actually to update the drug labels. And based on the signals that are basically come up in the post-marketing, we go back and, for example, we can require more cardiac studies to be done and be more rigorous in terms of evaluation. So I think from my perspective, we can't say one size fits all scenario based on, for example, mechanism of action of the drug, known, class sort of toxicities related to that class, the non-clinical studies, the early clinical studies findings, then we can actually at some stage, maybe it's appropriate actually to fully adjudicate for, some adverse events. It's not just cardiovascular, actually. We see, for example, in some trials, they adjudicate, for example, pulmonary adverse events or other adverse events. So it's just really depends on the scenario. And I think it just has to sort of like look at the totality of the evidence that comes actually in the light of that. And it's pretty much actually sponsors' responsibility to continue to do this. And they report these actually in an aggregate manner in terms of like, if they are expedited immediately or if they're not in an expedited fashion, like annually to the FDA. So we continue to monitor, and I'm really honored to be actually a part of this, and I'm here to listen, and actually hopefully I can take back some very useful information we can actually adopt, basically. Thank you. This was all.
Ollie, that's absolutely phenomenal perspective, and thanks a lot for your efforts. I think we all have great admiration for the FDA's work, particularly, I say, what's happened in diabetes. The regulators steering the field in the right direction has literally improved the care and management of millions of people. That sounds a bit cheesy, but it's really true. It's the FDA and the EMA have absolutely transformed that area. So I think we're hoping for a cancer trial friendly, cardiovascular event friendly process, which has got a good balance, as everybody's been talking about. So next up, we are honored to have Alice Chen, who is also going to talk about something which is pivotal here, which is the CTCAE, which is foreign to many cardiologists, but obviously has been central to cancer trials over the years. So we were extremely keen to hear, as well as a regulatory perspective, the perspective from CTCE, which Alice is one of the central pillars of. So Alice, we're really keen to hear your thoughts and perspectives.
Thank you for inviting me. I'm a medical oncologist and have been in early drug development for decades. I have been involved with CTCAE for the last 2 revisions for about 15 years now. From revision 3 to 4, which was an important revision because we changed all the CTCAE terms, which is common terminology criteria for adverse events, to meta terms, because trying to make it easier for reporting adverse events and looking at them. The opinion that I express here would be of my own and not those of the NCI. I think one of the importance of recognizing cardiac adverse events is that, since my husband's not around, I'll mention this. Years ago when I asked my husband about various cardiac events that comes up in drug development, the issue is he would say, well, they have cancer. Is it important to know what that event is? Well, I think we've improved the treatment for cancer. We've used a lot of these drugs now in neoadjuvant setting where patients potentially are cured, and long-term toxicities are very important. I think, not just in pediatric cancer where they actually have done a very good job in terms of treating patients, but now even in adults. So I think this think tank is extremely important because one, it's giving us perspective from regulatory, from cardiologists, from oncologists, from patient advocates, and many different standpoints in terms of recognizing these adverse events. I think somebody brought up bradycardia. As an oncologist, anything that's wrong with the EKG, any lab work that's related to the troponin, we don't really know how to put it all into the big picture, and really does require multidiscipline to really recognize that. But it is important to identify the adverse event, to recognize its potential causes, because not all of it's going to be from the chemo drug or the oncologic treatment. It could be from all the other drugs that we add on to manage toxicity. It could be just patient is 60 years old, history of hypertension, they went to heart failure, is it due to drug or not? Sometimes that is very difficult to really tease it all out. But I guess going back to CTCA, it's just some of the things that I think have discussed, that I heard discussed today. So now I have to figure out how to, So CTCA is actually a product of the National Cancer Institute and the Cancer Therapy Evaluation Program. Originally was developed for early drug development. And so you will recognize that some of the grade 2, 3 seem very severe, but these are because we're trying to develop new drugs. We need to kind of know when to stop drugs, when to restart them. It was started in 1983. As I mentioned, there's been several versions now. Version 5 was released in May of 2017. We actually have a helpline or an email, and we constantly monitor this email for comments regarding the version and any new toxicities if there's recognition of new adverse events. So we are working on version 6 at this point, and we are looking at all those comments that have come in, as well as we are requesting comments from our end users. And we'd love to, from today's meeting, if there are new things that needs to be considered, we would be, we'd love to hear about those. The purpose of it originally was designed to promote medical accuracy, to share data between different investigators and institutions. It is only a guide, and this is where I think it's important, and my pet peeve, that Physicians really need to be involved in terms of identifying the correct term to use and the grading, because all information is only as accurate and as useful as is what is put in. So if somebody does not put in the correct, diagnosis and all this, then it's not as useful. It promotes consistency in AE reporting and guidance for severity indicators. Within a clinical trial, patient eligibility. Patients have to resolve to grade 1 toxicity. They can't have more than grade 1 neurotoxicity before going on trial. Those are some of the uses for the CTCAE. Other is it defines how we report a severe adverse event versus an adverse event reporting. Grade 3s needs to be reported especially if it's unexpected. Dose limiting toxicity and maximum tolerated dose, especially for phase 1 trials, recognizing when we hit the dose or when we're too high in the dose and coming down in those doses. The definition for recommended phase 2 dose. When do we need to modify the dose? If somebody hits grade 3, 4 toxicity, you need to hold the dose. And when it comes down to grade 2, you can resume treatment or that you need to reduce the dose that's given. So these are all important things that for this. The other is for publication so that there's uniformity. If you're reporting for 2 different trials, use the same drug, wanting to know what the adverse events are for those. It provides some uniformity in that and is safety monitoring as well for these trials. For version 6, some of the events that's come up as we are looking at version 6, these are just some of the examples. There is a few more that's we're going through for some of the, especially like SITC, which is a committee that is involved or a society involved in immunotherapy, which is, I think, we're one of the large areas right now. We're trying to make sure we're up to date in terms of trying to capture adverse events, especially like myocarditis seen with these immunotherapies. But cardiac troponin, I think one of the, for CTCA, we had used the manufacturer because one of the comments has been that, well, the troponin is based on what test was used. So CTCA had used manufacturer guidelines based on whichever lab that was used. And yes, cardiac troponin can go up or for other causes, but CTCA is not actually an instrument for identifying causes as much as it is a grading of the severity. So the causes, it really is trying to decide if that is due to cardiac events or not is really outside of the CTCAE realm. The other is ejection fraction decrease. We had, 10 to 19% decrease. Somebody raised the question, is it a pure percentage decrease? Is it percentage from baseline? So these are some of the things that we're working on trying to, as we release version 6. So, things be very important to hear about any concerns people have about specific AEs within the CTCAE. The other thing we do with each new version is consider new terms. And these have been some of the terms that's been recommended. When we look at these terms, one of the things that we want to identify is this an important diagnosis? Is it due to drug? And is it something that can be changed? Can we manage it? So axis deviation on the EKG is probably due to another cause and is not itself a diagnosis of an event. And so we actually just for axis deviation, atrial enlargement, we had actually decided not to add those terms. But if somebody here decides that it's extremely important, would be very, interested in understanding why these terms should be added. But these are some of the other terms that we're working through to see if we should add these. The other big part with the ICI has been the syndromes. With version 3 to 4, we took out a lot of the syndromes. And I think that has been a concern for a lot of the investigators. And so we're going back to look at some of the syndromes to see if we should add any of those in. So these are some of the things that we are working on for version 6. And I really appreciate being part of this think tank, because this is a great time for us to kind of think about, are there gradings that needs to be changed, new terms that should be added? Are there definitions? I think heart failure is the other big one that we got a lot of comment on, that needs to be revised. And so would be very open to hear other people's opinion as we go through today's meeting. And the last slide is just, it has the email for if you have any information, any interest, new terms outside of from this meeting, please just send it to the email. We are looking at all the comments that came in. I do want to mention Shanda Finnegan, who has also been part of the CTCAE, is also in this meeting. So, 2 years are better than one. So thank you so much.
Well, thank you so much, Alice. That was a wonderful overview. And as you said, not everyone is familiar. And so having that history and sort of the framework is extremely helpful. And thank you for the openness. The email, I'm sure you're going to get a lot of interested folks engaging, which is, of course, the purpose of all of this. Well, maybe then just in the interest of time, we'll go to our third talk here. And Jim Januzzi is going to talk about the under and overcounting of events and events from miscalculations in oncology trials. So Jim, please go ahead. Thank you.
Thanks very much, Mark. And I want to thank the meeting organizers for including me. It's great to see the group on this call, many of whom are people I've had the pleasure of working with in the past. I've been given the oh-so-easy job of giving examples of possibly where we've gotten it wrong in the past. And I want to make sure that it's clear that that this is just a guide, a roadmap for possible next steps towards a different framework for how we think about judging safety and risk. My disclosures are seen here. I have actually, because I'm a biomarker researcher, have had a lot of contact with chemotherapy-related possible adverse events. But a more important disclosure actually is the fact that I'm really just a trialist with an experience in trial design, safety, and adjudication. And so much of what I'm going to show you is related to when we see examples that that might indicate an opportunity to take a different angle. So the question that I was asked is, are the events over or underreported? And I'll start first with a study published out of Javed Moslehi's group. And I know Javed was on, but he just sent me a direct message that he had to hop off. I hope he's still on, but this is an example of where we might actually be undercounting events, right? So I handled this paper as an associate editor at the Journal of the American College of Cardiology and was really struck by the results in this analysis, which again focuses on ibrutinib, which Javed mentioned earlier. And this is a post-marketing analysis using the WHO VIGI-base to identify the presence of cardiovascular events associated with ibrutinib. And what they did was they looked at timing of start of drug relative to events to really try to solidify the likelihood that there was a relationship. What the investigators found, besides 303 deaths that were associated with ibrutinib, they found, looking at the odds ratios in the table, a significant association with numerous events that we I as a cardiologist might think as important enough to at least know about, when patients are treated with these agents with respect to the relative excess of risk. And their conclusion was that there were numbers that were high enough to suggest that some of the cardiovascular adverse drug reactions might be underrepresented in the published data. So this is just one nugget of an example where, after the fact, looking back at the event rates reported, that things seem higher than were previously indicated. On the other hand, let me give you the flip side of the coin, which is maybe they are over-reported. And I'll share some experience as a cardiovascular adjudicator. I am not a cardio-oncologist. I'm not an oncologist by any stretch, but participated as an adjudicator leading a formal adjudication, re-adjudication of data focusing on ponatinib, a tyrosine kinase inhibitor. Now, newer generation TKIs have been generally associated with higher cardiovascular adverse event rates, generally speaking, compared to earlier generation compounds. In a clinical trial, the PACE study of ponatinib, the report was that the drug was linked to a higher than class arterial occlusive event rate, AOE rate, during the 5 years of follow-up in PACE. And these events were based on preferred terms, the MedDRA plus. Based on real-world evidence that the AOE rates associated with ponatinib were actually no higher than second-generation TKIs, a retrospective independent adjudication using formalized charter-based definitions for events was performed on the PACE study to try to understand, compared to the so-called pre-adjudication AOE rate, what the true or at least adjudicated rates would be. And what we found was across the board, everything was actually substantially lower, whether you look at greater than or equal to 1 AOE or serious treatment related or otherwise. The overall percentage of individuals in the trial suffering arterial occlusive events was lower. And so it was an overall numerical difference. But then when you look at the specific events, you see a trend developing, which is to say that when you look at symptomatic related AOEs that were triggered from MedDRA plus, such as angina pectoris or intermittent claudication, when subjected to formal adjudication, these actually were completely wiped off the map because they were often atypical symptoms that had no clear evidence for an acute arterial occlusive event. As well, serious events such as myocardial infarction or stroke were still numerically quite measurable, but they were less than what were linked using MedDRA plus. And this gets to the challenges of adjudicating acute myocardial infarction using, using symptoms or what's written on paper rather than using formal adjudication, such as using the universal definition of MI, EKGs, etc. Same thing goes for adjudicating stroke, which any neurologist that participates in clinical trials can tell you is a big challenge. Lastly, of the really relevant events besides the MI and stroke rate, cerebral infarction, peripheral occlusion, PAD requiring revascularization, those rates weren't all that different. And so it really illustrates that for the major events, you see pretty consistent findings, but much improvement, one could argue, could be made with respect to the accuracy of judging of events. But I'll give you my N of 1, since we're talking in an oncology meeting. I have a patient with cardiovascular disease, coronary disease, and heart failure with leukemia that was switched because of treatment failure to ponatinib, and their oncologist called me because, quote, this drug is worse than the others with respect to cardiovascular event rate. And so there's a clear need for clarity about these issues. And so, I'm really pleased that Anna is on this call, and, I'm showing data from many colleagues that are on this call, but to steal this figure, I thought was really important because in a recent editorial that Dr. Barak wrote, entitled "With a Riff on All the Light We Cannot See," with unprecedented growth and expansion of indications for oncology therapies, the need for understanding events, even if it's just to be able to prognosticate in the future what to expect, has never been larger. And this will require collaboration with our colleagues at CTCAE, pharmacovigilance studies, and then those of us in the clinical trial world who are experienced in assembling the approach to adjudication in a formal way for not all, but certain therapies is really quite necessary. So to answer the question, is there over and under counting? Yes. I think there is, but we certainly don't want to slow things down. As a trialist, that would be obviously bothersome to me, and as a clinician, even more so. So the discussion really revolves around in which trials should events be adjudicated, what events should be adjudicated, and how to adjudicate them. You know, a week does not go by that I do not get a call as a biomarker researcher about a rise in high sensitivity troponin associated with the chemotherapy agent. Is it an MI? No. Is it myocarditis? Probably not. So the question is, you know, what do we do with those results? And so having definitions will be strict, I think, critically important if we decide to go that route. So I'll stop there. Thanks very much.
So Jim, that was spectacular. And I think it's really important to emphasize the ponatinib example, because by looking just very simply at potential cardiovascular events, we can see that these drugs could be safer than previously thought. So really phenomenal to hear that. So we're going to move on now to the very last talk, but last but very much not least is Ninian Lang. And then we're going to move on to breakout groups where we're going to hear everybody's input and opinions. So Ninian, really keen to hear your presentation.
Yeah, thanks, Mark. Nice to be here. So I'm Ninian Lang. I'm a cardiologist, cardio-oncologist, run a service in cardio-oncology here in Glasgow, in Scotland. And I really just wanted to flag up some of the things that I think are issues with the ways that we capture endpoints at the moment. And actually, I'm encouraged because I don't think actually I'm going to be saying anything that's particularly controversial, having heard the general direction of conversation and reading the chat. But I just thought it was worth putting things out in black and white. Here are my disclosures. So as I said earlier, the first issue really is that often cardiovascular events are just not reported at all in oncology trials. These are trials, phase 2, phase 3 from 1998 to 2018, and somewhere between 20% and 55% of trials do not report adverse cardiovascular events at all. And as I said, that may well be a little bit better with the targeted therapies, but still there is room for improvement. When those events are reported, we are very reliant on CTCAE, and you know, I think we've flagged some of the challenges already with CTCAE. I'm using heart failure here as an example, but actually I think you could probably apply this to any of the cardiovascular presentations around. And I think we could help to improve this. Currently, if someone presents with symptoms which may be compatible with heart failure, there are 8, potentially 9 different categories into which that patient might be able to be put. And that's not just an issue in terms of counting the events, but also depending on the heading of that category, the grading of the severity is also variable. So you can present with the same thing, but fall into several different categories, all with different severity gradings. The other issue is that we don't necessarily, as cardiologists, necessarily recognize some of these terms. So for example, grade 1 heart failure, an asymptomatic patient with some cardiac biomarker abnormalities, I think we would probably not recognize that as a heart failure presentation. There are other things. So pulmonary edema is considered currently as a respiratory disorder. And one of my own personal bugbears is patients, and particularly in trial reports, of edema. I really don't think we know what edema is. Can we do better than this? I'm sure we can. And this may be one of the things we can think about in the breakout, whether or not edema is an unacceptable endpoint. And actually, if someone presents with edema, we should be categorizing further and having a drop-down list of further assessments on that. But that's not to say that CTCAE is the only group that we have difficulty with. We have difficulty within ourselves as cardiologists and oncologists. We haven't even been able until recently to be able to agree what a normal cutoff for left ventricular ejection fraction or change in left ventricular ejection fraction is to define cardiotoxicity. But I think that's quite a good moment now to introduce some work from the International Cardio-Oncology Society, trying to harmonize the definitions of the key cardiovascular toxicities. This is currently in press at the European Heart Journal. Sorry, we can't share the final publication, but this has been a major effort involving a lot of people on this call to try and harmonize these definitions, not just for heart failure, but for most of the potential presentations with cardiotoxicity. And I would see this as a major opportunity to try and harmonize this and integrate this into CTCAE, and ideally to help rationalize and actually reduce the number of potential categories into which patients might fall in CTCAE. So to reduce the number of terms rather than to add complexity. Some thoughts a little bit about clinical events and surrogate markers. Now, clearly, they're both important, they're both complementary, but it's worth pointing out that clinical events reporting is definitely clinically relevant. It's meaningful for patients and it's meaningful for the clinicians. But reporting is subjective, even with the best reporting systems in the world, and it depends on the consistency of clinical assessment. Now, that's not just regional, but particularly in these trials, that's specialty specific, and particularly in the oncology community where so many potential cardiovascular symptoms can be confounded by oncology diagnoses, anemia, breathlessness, ankle swelling, hypoalbuminemia, just to name a few. And in terms of surrogate marker recording, and by that I really mean left ventricular ejection fraction and humoral biomarkers. Of course, these are objective and hopefully relatively easily incorporated into trial protocols, although we may have some discussion about how easy it is to incorporate cardiac imaging. But there may well be some disconnect between biomarker changes and clinical events, particularly in isolation when we don't know what the delta is. Final thoughts to consider really is that baseline cardiovascular assessment, I think as we all know and we already highlighted, it's infrequent, and when it's done, it's not been standardized. So I think there's an opportunity to improve on that. Changes from baseline are most relevant. And of course, the effects of these drugs need to be established in the context of the baseline cardiovascular status. We need to understand that to understand the best ways of treating cardiovascular toxicities when they occur, and to understand their relevance in the context of the competing cancer diagnosis. Moving on from the baseline assessments, longitudinal follow-up with even just clinical assessment, whether or not that also includes biomarkers or imaging. Really, the active surveillance is really much less common than the current status, which is mainly in voluntary reporting. Who gets what, how, and when is not standardized, and I think that's a major point for discussion. And the last point I'd like to make is that a lot of trials in cancer involve short-term exposure to cancer therapy. While we're keen on long-term follow-up for events, this of course introduces difficulties with attribution of those to a drug, in particular when you've got the competing effects of the cancer diagnosis and often multiple other oncology drugs in isolation or in combination. So with that, I'll finish and hopefully stimulate some thought for the breakout groups.
Fantastic talk, Ninian. Just wonderful, and really, I think, encapsulated a lot of the discussion. Obviously, hard to cover all of this in just a couple of hours, but we're going to go, I think, into our breakout groups now for about 20 minutes, and then we'll reconvene. And this is, of course, just the beginning of the conversation. We have two breakouts, A, which is event definitions, and B, which is adjudication strategies. Ninian and myself will be in A, and then Mark and Jim Januzzi will be in B. We look forward to some good discussion there as well, and then we'll come back. And of course, all of this is recorded, so you can sort of get the benefit of both after the call. So I guess to our coordination team here, if you could help us get into our appropriate rooms, that'd be great.